Welcome to the Mind Cuts series. We've got a really fascinating stack of research and articles from you all this week. It's all centered around weight management, the science behind it, and, well, all the buzz around GLP-1 medications.
Right.
Our goal here is to really cut through those headlines. You know, pull out the solid, evidence-based stuff that matters for your health, whether this is something you're personally dealing with or maybe someone you care about is.
And, for everyone listening, I think it's so important to start with this point that came up in several pieces you sent. Weight loss. It really shouldn't take over your life, not mentally, not physically. It is absolutely okay to get help. The science is showing more and more that obesity is complex. Struggling with it doesn't make you a failure at all. It just means you're human, right? In a world with, frankly, a lot of challenges. And maybe for the first time, we have real options beyond just, eat less, move more.
Yeah, that old chestnut. We're really lucky today. We have an expert who can guide us through all this material. She's triple board certified endocrinology, obesity medicine, internal medicine, an expert in metabolic health, founder of New York Endocrinology, and teaches at NYU Langone. And our focus, as one source highlighted, is really on prevention and sustainable solutions. So let's dive into your material with her.
Thanks for having me. And, to the listeners, based on what you shared, I actually want to start with an apology, really, on behalf of healthcare providers.
Oh, right.
Yeah. We haven't always had the full picture. We've failed a lot of people in the past who are looking for help with their weight. Honestly, learning from my patients has been incredibly humbling. And it's just clear our understanding has changed. It's evolved so much.
Right.
The good news, though, and this is reflected in the research you're seeing, is that the science is moving fast. We're really getting better at tackling this complex issue effectively.
That's such an important shift in perspective to hear based on the science you've all been reading. So a key theme seems to be reframing obesity not as some kind of personal failing, but as a disease. Why is that reframing so critical?
Because it has serious health consequences. That's what the data shows, loud and clear in the sources you sent. It significantly boosts your risk of mortality, and it's a major risk factor for, get this, over 15 different cancers.
15?
Yeah, including breast cancer. Some studies even point out obesity is a bigger risk than things like alcohol or hormone replacement therapy or even genetics sometimes. And it's a leading risk for pancreatic, colon, prostate, thyroid cancers too. So for you listening, understanding this means tackling obesity isn't just cosmetic, it's fundamental to cutting your risk for a whole range of really serious diseases, diabetes, hypertension, heart disease.
It's really striking reading some of those personal stories you included, how much judgment and shame have been tied to weight historically. It really sounds like the medical world, based on these newer studies, is finally moving away from blaming people.
Absolutely. And, if you've felt that judgment or seen it, it's important for you to know that we in healthcare often operated under those same, misguided views.
Right.
Patients would come for help, and honestly, we often didn't have the right training or a deep understanding of what was really going on biologically. It's crucial for you to grasp, like your sources emphasize, obesity isn't some self-inflicted thing rooted just in a lack of willpower.
Okay, let's really dig into that. That's a powerful statement for our listeners. Obesity is not self-inflicted. What does that actually mean, medically speaking, based on the research you've gathered?
Well, what we've learned and what your materials really highlight is that obesity is multifactorial. It's a chronic disease with multiple underlying causes.
Multifactorial.
Yeah.
Meaning lots of different things contribute.
Exactly. I usually break it down into 5 main areas for people. First, there's lifestyle, exercise, being sedentary, diet. And lifestyle is only one piece of this whole puzzle.
Okay, only one. What else?
Second is genetics. There are specific genes that can predispose you, sure, but it's also just broader family history. Weight patterns often run in families, right? And interestingly, some research you sent points out that your parents' weight before you were conceived can actually influence your weight later on.
Wait, really? Preconception weight? I don't think many people know that.
Yeah, it's what the emerging science suggests. Okay, third factor, hormonal changes. Things like PCOS, polycystic ovary syndrome, that messes with metabolism. And of course, perimenopause and menopause in women. Big hormonal shifts there.
Right. Definitely hear about that.
Fourth is just aging.
Yeah.
Sucks, but it's true. Metabolism slows down naturally. We tend to lose muscle, store more fat. It happens.
Cool.
And finally, number 5, environmental factors. This is huge. Think the food industry, processed foods designed to be hyper-palatable, make us want more. Also, obesogenic environments, places where it's hard or unsafe to walk, even just working from home more, being more sedentary. And then there are endocrine-disrupting chemicals, BPA, and plastics, pesticides. Some research suggests they mess with our hormones and promote obesity too.
Wow, okay. Listing those 5, lifestyle, genetics, hormones, aging, environment, it really drives home how much is actually outside of our direct control. Lifestyle is really the only one we have major influence over, isn't it?
Exactly.
So for listeners who've been, killing it with diet and exercise, but not seeing the results they expect, this explains a lot.
It really does. It makes perfect sense why someone can be doing everything right with diet and exercise, that lifestyle piece, but still struggle. They're basically fighting against these other powerful forces, genetics, hormones, aging, their environment.
So understanding this and classifying obesity as a chronic disease, how does that change the treatment approach? What tools become available, according to the sources you've been reading?
It fundamentally shifts the dynamic. It moves us away from blaming the patient. It becomes more of a team effort, doctors working with the individual.
Like other chronic conditions.
Exactly. Think about type 2 diabetes or high blood pressure. We routinely prescribe medication for those, right alongside lifestyle advice.
Sure.
The medication doesn't replace healthy eating or exercise. It complements it because we know there are underlying biological things going on. We can now approach obesity the same way, acknowledge the factors outside of someone's control, and offer medical tools to help.
Which brings us right to the topic so many people, including our listeners, are curious about. GLP-1 medications. I think a lot of people assume these are brand new, but one article you sent mentioned the first one was actually approved way back in 2005?
Yes, that's right. 2005. The very first one was Byetta from Eli Lilly. And interestingly, it was a twice-daily injection.
Twice a day? Wow.
Yeah, subcutaneous. Patients had to inject themselves twice every single day. And the initial approval was specifically for type 2 diabetes.
Okay, so for listeners who aren't medical experts, can you break down GLP-1? What does it stand for and what does it actually do in the body, simply put?
Sure. GLP-1 stands for glucagon-like peptide. A peptide is basically a short chain of amino acids, and this one influences hormone secretion. The discovery story is actually pretty wild. It came from studying the venom of the Gila monster.
The lizard?
Yeah.
Seriously?
Yep. A researcher, Dr. John Eng, was trying to figure out why its venom caused pancreatitis inflammation of the pancreas in its victims. He isolated GLP-1 from the venom.
That's incredible. Lizard venom to diabetes drug. So what was the initial thinking on how GLP-1 worked?
Initially, the understanding was that it stimulated the pancreas to produce insulin, very relevant for type 2 diabetes, which involves insulin resistance and often high insulin levels, or hyperinsulinemia.
Right.
See, when the body becomes resistant to its own insulin, the pancreas works harder, pumping out more and more insulin to try and compensate. It's a vicious cycle.
Okay, so it helped with insulin production for diabetes. How did that lead to weight loss? That seems like a bonus effect.
It was definitely an unexpected but very welcome benefit. It happens a lot in medicine, actually. Patients with type 2 diabetes taking these early GLP-1s, well, their blood sugar got better and they started losing weight. Which was pretty different from many other diabetes meds at the time that often caused weight gain. So around 2010, some doctors, including myself, started exploring its off-label use for weight management.
Got it. And the official approvals for weight loss came later?
Exactly. Saxenda was approved in 2012. That was a daily injection, still had quite a few side effects. Then Ozempic in 2017, initially for type 2 diabetes, and finally Wegovy in 2021.
Wegovy and Ozempic are the same drug, right?
They are, semaglutide. Wegovy was just specifically studied and FDA approved for weight loss, even in people without diabetes. The different branding is partly marketing, partly for insurance coverage.
Okay, so for someone listening, how exactly do these drugs work for weight loss, even if you don't have diabetes? What's the mechanism?
Basically, they tackle the two main reasons we eat: fuel for survival and reward.
Fuel and reward, okay.
For the fuel survival part, they suppress appetite hormones and boost satiety hormones. So you feel full much faster when you eat, like maybe with only a third or half the food you used to eat.
Wow.
And you feel less hungry between meals because those hunger signals are dialed down. Many patients find they naturally just eat maybe 2 smaller meals a day and feel fine, physically satisfied.
And the reward part.
Right.
Yeah.
We actually have GLP-1 receptors in the brain in the reward centers linked to food and even alcohol. These drugs block that reward response.
So food just isn't as satisfying.
Exactly. If you used to get a big pleasure hit from certain foods, on these meds. It just doesn't deliver the same feeling, which understandably leads to big changes in eating behavior. And importantly, like we said, if your blood sugar is normal, they don't make your pancreas pump out extra insulin.
Okay, so key takeaways.
Yeah.
Less hungry, full faster, and less desire for those rewarding foods. Makes sense. Now, we see a lot in the media and probably in some articles listeners sent about people maybe using these for smaller weight loss goals or the whole Ozempic face thing. For our listeners, who are these meds really for? When is someone a good candidate?
Well, first, we really need to challenge this idea that just being thin equals being healthy. It doesn't.
Right. Good point.
Someone can look slim, but not be metabolically healthy. And someone who isn't thin might have a perfectly healthy body composition. That's why body composition analysis is so vital.
Measuring fat versus muscle.
Exactly. Ideally, everyone should get it done, honestly, even if they don't think they need weight loss meds, just to understand their own makeup.
Okay.
When we talk weight loss, we really mean fat loss, right? We want to lose the fat that increases disease risk, not precious muscle. Body composition shows us your body fat percentage, including visceral fat, and your muscle mass. You can have someone who looks slim, but is actually skinny fat, low muscle, high body fat, sarcopenic obesity. They're still at risk.
This is not just about appearance at all.
Not at all. We need to move past equating thinness with health and figure out your individual composition. Often patients who think they only need to lose, say, 10 pounds are surprised when the analysis shows they actually need to lose significantly more fat and gain muscle. So judging candidacy just by looking at someone doesn't work. Body composition is key.
That makes so much sense. So how do you actually assess if someone's a good candidate? What do you look at in your practice?
It's pretty thorough. I start with a deep dive into their weight history. Like, when did they first become aware of their weight? When did they start trying to lose weight? Has anyone told them they needed to? For many, this goes way back to childhood.
Wow.
Then a detailed medical history, any other conditions, medications that might be contributing, a really deep family history, parents, grandparents, even their kids' weight patterns.
Interesting.
For women, gyn history is important, perimenopause, menopause, PCOS, and then the physical exam, which absolutely includes body composition analysis. It gives us a full picture to see what needs work and if a GLP-1 is the right tool.
Is there a specific body fat percentage that flags someone for needing intervention, generally speaking?
Generally, yeah. We define obesity by body fat percentage as 32% or higher in women. Normal is more like 18-28%. For men, obesity is 20% body fat or higher, with normal being around 10-20%. Anyone above those normal ranges is usually considered overweight or having obesity.
Okay. And you mentioned hormonal changes earlier. Thinking about menopause, is there a particular benefit for women going through that stage to consider GLP-1s?
Absolutely. During perimenopause and menopause, that drop in estrogen really shifts body composition. Women tend to gain more visceral fat, that belly fat, and lose lean muscle.
Right.
So many women who never really struggled with weight before suddenly find that what used to work just doesn't anymore. They'll say, I'm doing everything I used to, even working harder, and nothing's happening.
I've heard that exact thing.
It's largely those hormonal shifts in aging. So in that context, GLP-1s can be incredibly helpful. They can help counteract that increased tendency to store fat and make weight management more achievable again.
Okay. Are there situations where someone absolutely should not take these medications? Any definite no-goes?
The main absolute contraindication right now is a personal or first-degree family history of a specific type of thyroid cancer called medullary thyroid carcinoma. It's rare, but aggressive.
Medullary thyroid cancer. Got it. Other thyroid issues are okay.
Other more common thyroid cancers aren't an absolute stop sign, no. Also, they're generally not recommended if someone is pregnant or breastfeeding.
Okay. Now, a big question listeners might have.
Yeah.
Do you have to stay on these forever? Is it long-term, or can it kind of reset things? What's realistic?
Well, we have to remember obesity is a chronic multifactorial disease, right?
Oh.
So if we use medication to help someone reach a goal weight and then just stop it, all those underlying factors are still there.
Genetics, the hormones.
Exactly. The aging, the environment, they haven't gone away. So like with other chronic conditions, the goal is often control, not necessarily a cure. These meds were generally designed with long-term use in mind.
But not always.
It can vary. It's very individual. Someone who's struggled with obesity since childhood probably needs long-term management. But maybe someone who gained weight mainly after having kids and then hit midlife, but was never significantly overweight before, maybe they don't need it forever. It really depends on their history.
That's a really helpful distinction. You mentioned your own experience using a GLP-1 briefly after having kids later in life and hitting perimenopause. You used it for about 6 months, right? And have maintained since. What was that like, being the expert but also the patient?
It was interesting. I wouldn't say I resisted it, but I was kind of watching, waiting, seeing if things would shift on their own. After a couple of years with young kids, I realized, okay, despite my efforts, the weight wasn't coming off. And I knew, given my family history, hormones were likely a big factor. I tend to be proactive, so I decided, let's try this. It helped me get back to a weight that felt healthier for me. And then, I've been able to maintain it with consistent exercise. But going through it myself, it absolutely gave me a much deeper empathy for my patients. It just reinforced that sometimes, even with the best lifestyle efforts, other factors mean you need extra support. It's not failure.
That's so valuable for people to hear. Okay, let's talk risks. What are the key things listeners should know about potential downsides?
Well, like anytime you significantly reduce calories, there's a potential risk of losing muscle mass along with fat. It's hard to only lose fat.
Right.
So it's more of an indirect effect. The drug itself isn't attacking muscle, but if you're eating way less, you might not get enough protein to maintain your muscle.
So it's not inevitable muscle loss. What can people do about it?
Oh, absolutely not inevitable. We can definitely mitigate it. Educating patients is key, hammering home the importance of protein intake while on treatment. That can prevent significant muscle loss, and some people even gain muscle if they need it. And strength training. Crucial.
So practical advice.
Yeah.
Prioritize protein, lift weights.
That's the core of it.
Why is keeping that muscle mass so important, especially when losing weight? What does it actually do for us?
Muscle is your metabolic powerhouse. Seriously. Think of it as your calorie-burning engine. More muscle means you burn more calories, even just sitting around.
The resting metabolism.
Exactly. And muscle is huge for regulating blood sugar. When your muscles contract, they literally pull sugar out of your bloodstream for fuel. That's why even just a walk after eating helps your blood sugar.
Okay.
When people lose weight and their metabolism slows down, a big part of that is often losing muscle along with the fat. So keeping or even building muscle while on GLP-1s makes the fat loss much more effective and sustainable. Your muscle mass really dictates how well you lose fat long term.
So specific recommendations again for preventing muscle loss on these meds. Actionable stuff.
2 main things. Strength training. Aim for at least twice a week. Doesn't have to be crazy bodybuilder stuff. Upper body, lower body split is a great achievable goal for most. Consistency is key.
Okay, twice a week, strength training. And protein.
Yep, increased protein. I usually aim for around 90 to 100 grams a day as a target. That might sound like a lot, especially when your appetite is lower.
Yeah, how do you manage that?
You have to prioritize it. Make protein the focus of each meal and snack. Lean meats, fish, eggs, dairy, beans, lentils, tofu, protein powders. Consciously add them in. It's really the crucial first step.
Got it. Now, that Ozempic face thing we hear about, what actually is that? Is it the drug itself doing something weird to faces?
No, not directly. Ozempic face is really just a consequence of rapid or significant weight loss, especially if it includes muscle loss.
Oh, okay.
If you lose muscle because you're not getting enough protein, you'll likely lose facial fat too. And protein is vital for collagen and elastin, the stuff that keeps skin firm. Muscle also helps sort of fill things out where fat is lost. So if you lose both fast, you can get that gaunt look, maybe hair thinning, less skin elasticity.
So the goal isn't just skinny, it's strong and fit.
Exactly. Gradual weight loss, plus really focusing on that protein intake, helps the skin adapt better. So for listeners, slow and steady with enough protein helps minimize those aesthetic changes.
What about other side effects? We hear about things like nausea, indigestion, even warnings about suicidal ideation have popped up in some reports.
Yeah.
What should listeners know?
Okay, this is where the prescriber's expertise is absolutely critical, both for effectiveness and safety.
Right.
These are serious medications. They need medical supervision. That helps minimize side effects and make sure everything's optimized. Personally, in my practice, I've never had to stop someone's medication because of those symptoms you mentioned.
Really?
Yeah. It takes time, though. You have to really explain things, build trust, talk openly about potential side effects and how we'll manage them if they happen. That takes more than a quick 15-minute appointment, which is why I prefer my private practice setting.
That makes sense.
So the takeaway for listeners: find an experienced provider who supervises you closely. That's key for managing side effects and getting good results safely. And be really wary of mail-order GLP-1s or med spas offering these without proper medical oversight.
That brings up a really important point. With all the online options now, what should people look for in a practitioner? What are the red flags?
Okay, first thing to understand, medical doctors typically don't sell FDA-approved meds directly from their office. We write a prescription, you fill it at a pharmacy.
Right.
If someone's selling you the drug directly, it's almost certainly a compounded version. A lot of mail order places, some telemedicine platforms, they're using compounded versions too.
And what's the difference? Why does that matter?
Huge difference. Critical for safety. FDA-approved meds, they've gone through rigorous trials, years of research, heavy regulation for safety and efficacy. You know what you're getting.
Okay.
Compounded meds, not FDA-approved, not regulated. There's no guarantee they actually contain what they say they do, or the right dose. They might have fillers. The risk of side effects, even overdoses, is much higher because dosing is often inconsistent and left up to the patient.
Wow, that's alarming.
It is. And sadly, most hospital visits for severe GLP-1 side effects, they're linked to these compounded versions. The FDA-approved ones mostly come in pre-dosed pens now, which helps prevent dosing errors. So bottom line for listeners, stick with FDA-approved drugs prescribed by a licensed doctor providing ongoing care.
That's a crucial distinction. What about this trend of microdosing GLP-1s? Especially for people maybe without much weight to lose. Is that safe? Effective?
Well, we need to think about how drug doses are set. They come from clinical trials showing what works the therapeutic dose. That's what gets FDA approval.
Okay.
If you're talking microdosing, using a tiny sub-therapeutic dose, it's probably not going to do much for actual weight management if someone has obesity. They need the therapeutic dose.
And for people who don't need to lose weight?
If someone's already metabolically healthy at their weight, they already have those benefits. They don't need the medication. Plus, microdosing usually involves those unregulated compounded drugs again. The FDA-approved pens aren't really set up for easy microdosing anyway, except maybe one specific vial formulation of tirzepatide that's newer. Often, the whole idea of microdosing comes from trying to avoid side effects.
Which you said are often linked to the compounded ones anyway.
Exactly. Side effects are much more common with improperly prescribed compounded versions, not inherent to the FDA-approved drugs used correctly under supervision. So for listeners, the reliable path is FDA-approved meds, therapeutic doses, doctor's guidance.
Got it. What's the biggest misconception you run into about these GLP-1s when you talk to patients?
Oh, easily the idea that it's the easy way out, that it's cheating, that people just sit back and don't have to worry about diet or exercise anymore. I hear it constantly.
In the reality, what do you actually see happening?
The reality is patients often become more engaged in healthy habits.
Really? How so?
They're often more motivated, they exercise more, they focus on eating better, especially getting that protein in because they understand about muscle loss, and they're actually seeing positive changes in their body composition.
Ah, they see it working.
Yeah. There's often this mental switch. They start focusing less on just the number on the scale and more on how they feel stronger, more energetic. They actually start asking about gaining muscle and follow-ups.
That's fascinating.
And for patients who've struggled for decades, tried every diet, every exercise plan, it's not that they didn't want it enough before. It's that those other factors, genetics, hormones, etc., made it incredibly hard. I honestly haven't met anyone who got significantly overweight just by being lazy. People are usually trying really hard, just fighting uphill battles.
So it's a tool to help their efforts finally pay off.
Exactly. So if you're listening and feel like you've tried everything, know these can be a legitimate tool to support your efforts.
It really hits home that it's not about willpower. Now, I'm curious, and listeners might be too, how do these meds change someone's relationship with food, like how much they think about it?
Gosh, anything I say probably won't fully capture it. For so many people struggling with obesity, thoughts about weight and food are just constant, 24/7. Every bite can come with guilt or anxiety. To have that mental burden lifted, it's life-changing. Patients describe it as feeling liberated, like endless possibilities open up. One person told me it was like the food noise in her head finally got turned off.
Wow, food noise. That's powerful. I actually have a family member on one, and that's exactly what they said. Just not constantly thinking about food was a revelation.
It is. Some patients literally say, oh, so this is how normal people feel. It really shows how much mental real estate was taken up by food and weight thoughts. It can shift your whole perspective on portions, habits, and it can ripple through families, too, as they see the positive changes.
For someone listening who's worried about a loved one, how can they bring up seeking help without making them defensive? It's such a sensitive topic.
It really is a very delicate conversation, even for us doctors. Some people just aren't ready, But I think if it truly comes from a place of love and genuine care, people usually sense that. They're less likely to feel attacked.
So lead with care, not blame.
Definitely. Remember, people struggling with weight have often faced so much blame already. Sensitivity is key. Maybe even sharing some of what you learned today about the complexity could be a gentle starting point.
That's good advice. What about affordability? If insurance denies coverage or it just seems too expensive, are there options?
Yes, definitely look into manufacturer coupons. The drug companies often have programs that can cut the costs significantly, maybe 50–60%, even without insurance coverage. Check their websites.
Okay, coupons. Anything else?
Also, like I mentioned, some companies are now offering vial formulations like insulin vials, which can be considerably cheaper than the pre-filled pens.
Good to know.
And seeing a specialist, an obesity medicine doctor, can sometimes help. We might be better at navigating the insurance justification process to try and get approval.
Okay, helpful tips. If someone listening takes just one action today after hearing all this, what would you hope it would be?
Just to really think about this complexity we discussed. And maybe, just maybe, share that understanding with someone else who might be struggling. Knowing it's not just about willpower and that real help exists, that can be incredibly empowering.
Dr. Salas-Whalen, any final words for our listeners?
Just to reiterate those two key things. One, please remember it's not your fault. And two, it is okay, truly okay, even courageous to get help. Seeking help isn't failure. It's not cheating. It's acknowledging how complex this is and using the effective tools we finally have beyond just eat less, move more.
Thank you so much, Dr. Salas-Whalen. This has been incredibly insightful, helping us navigate all the information in our listeners' sources today. Really appreciate your expertise.
My pleasure.
And thank you to you, our listener, for joining this deep dive. Please do share this with anyone you think could benefit. We absolutely believe in your ability to take care of your health and use the tools out there for you.